Hey, welcome in everybody. It's Dr. Shane back with a little discussion today. Wanted to talk with a former hospital executive, former hospital bigwig, gentleman who's seen both sides of the coin, Mr. Heat Veuleman. Hopefully, I got that right. Um,
Very, very close.
Very close. So I'll let him introduce himself. Give us a little bit of a background because most of our DPC docs and primary care docs don't recognize you, don't know who you are, even though you're out on X and a lot of social medias. But I wanted to share some of your story because I think they need to see the other side, the hospital side, the executive side, and so share a little bit about how you got into it. I know you started when you were young. I've seen some of your videos and podcasts. You started when you're young, got into the hospital executive side and kind of left that doing other things now. So tell us a little bit about why you did that, how you got in there, why you left, that kind of stuff.
Yeah, I started when I was very young. I started when I was 20. The summer I was going to turn 21. I was hired in July and then turned 21 in August for a hospital. And the reason is because I couldn't get into med school. I
Mm.
tried and had a problem with authority and got into arguments at both of my interviews, one at Tulane, one at LSU Shreveport. And they did not go well. And it's just the way the universe works. It's funny. I ended up the chancellor who happened to be in the LSU Shreveport interview became a client later down the road in a different situation. So, we made nice 15 years later, but uh, uh, that's actually how I got into hospital administration. There was a PhD program. I wanted to do psychiatry, and so I was like, well, I'll do a psychology PhD program. LSU was the only one in the state that had clinical PhD. There was a counseling PhD at Louisiana Tech, and I really wanted to stay in state, and couldn't get into either one of those. And uh, this lovely lady that was a CEO of a hospital asked me to come start clinics and hired me as a director of clinics. And that's how I started and started doing clinics in the delta of the Gulf South in between Louisiana and Mississippi on the Mississippi River. And it was just a wonderful experience. It was extraordinarily challenging, but really, really great experience.
And those were clinics like health clinics, primary care. What kind of clinics was
Yeah,
that?
that's exactly right. There is a type of clinic called a rural health clinic, and it's federally certified, state licensed. They get capitated payments, and these were started around 1968, maybe 1970. A Section 330 grant um, was really how these programs got started, and their sisters would be called a federally qualified health center. So you have like
Mm-hmm.
a rural health clinic, and then you have that classical Section 330 federally qualified health center, and they're built around mid levels. And the theory was we couldn't recruit physicians to rural areas, so we would start these clinics that got higher than average reimbursement, build them around nurse practitioners with physician oversight, and you would get higher than normal reimbursement. Of course, we've gotten to, and I've done a lot of those, done a lot in my career. I did a lot of rural health clinics across this nation, did a lot for hospitals. But now, what you see, if you look in the Medicaid data that was released, a month ago now from HHS, the first real look for most people, well, that is the second highest billed code, that capitated code.
Mm.
So, rural health clinics definitely have their place, but that reimbursement has been abused for sure.
Wow. And did you get later at some point, did you get more into the C-suite type jobs or CEO level type
Yeah,
jobs?
absolutely. It started when I left the hospital, the first rural hospital, and opened my consulting firm. Uh, that's basically what I was doing. Was a lot of regulatory compliance, and then went into kind of executive roles for health systems. I would come in for a temporary period of time and roll out whatever they needed.
Hmm.
And then I started working for large multinational corporations and governments to do very avant garde healthcare delivery and financing systems. And then 2020, I was sitting in a hotel room, and a law firm from Chicago called and was telling me about a physician-owned hospital that the government was trying to close. And I remember I had on the news, and I was sitting at this little desk in this hotel room, and the news was talking about, well, we don't have enough licensed hospital beds available to the general public. And I was like, well, this is a crazy disconnect. What's going on? And then it clicked with me. Oh, this is physician-owned hospitals. And whenever we were, certainly had to do things with the American Hospital Association or state hospital associations, and the idea was we did not want physician-owned hospitals. They were kind of a gnat, and they sent me over a reading file on this particular client, and I was like, I can't believe this is happening. This is crazy, and started falling down the rabbit hole of physician-owned enterprises and realizing I had been part of the problem for all of these years. And so, since 2020, I've been trying to help physicians and physician-led enterprises and fix the disconnect that I helped create, which is very, very simple. It is the issue is healthcare is really not different than any other industry, although we make it out to be. The issue is dislocated capital, and that sounds very consultancy, but in every transaction, you have a buyer and a seller. Every time I add an intermediary between the buyer and the seller, the price goes up and the quality goes down. There is no industry where I add an intermediary between a buyer and a seller and quality goes up and price goes down. That doesn't happen. It's just really, really basic economics. And so what I'm trying to help physicians do is kind of reconnect with the consumer and eliminate all of these intermediaries, third parties.
Yeah. Well, that certainly sounds like what most hospitals aren't doing,
Right.
trying to connect with consumers. What I'd heard once before, a huge hospital CEO say this. I don't know if he really meant it, but he said his mission was to take care of the community so good that it would close the hospital down. And I said, well, that's a great mission. I don't know that was really what they believed in their heart. And so, my question to you is what should be, we live in and where I'm at, fairly small community, 400-bed hospital, pretty generous size hospital. Well, what should a mission, even a small hospital in a rural area, a 20-bed little rural hospital, what should the mission be, right? That's my question
Yeah.
is for the CEO, for the community, what should the mission be? With things that you've seen, what's the mission of a small hospital like that?
So you got to work your way backwards. This is a Charlie Munger truism, is invert the problem. So if I'm trying to get healthcare to a consumer, and that is my goal, then what I was trained to do and what we were really trying to do before hospitals got into this crazy world of being a payer provider, which is what people would talk about. That's what is actually happening right now. If I want to get to the consumer, I need the physician to have as much agility within a system of care as possible. So I, as a hospital, should be designing a framework for the physician and the patient to have as much access and information between each other as possible. So, but that's not what hospitals are doing. What hospitals are doing is really using the system as a wheel, and this is what it was like in grad school, described as the hospital system is a wheel. Physicians are cogs, patients are widgets, and the wheel produces widgets, and I need the cogs to spin the wheel. And so that is the way, unfortunately, health systems and hospitals see physicians, is I need you in the wheel producing these encounters over and over and over again. And unfortunately, hospital CEOs, we're not exactly the smartest people in the world. And so what happens is in healthcare is extraordinarily insular, especially executive management of hospitals and health systems. There's only 6,093 the entire nation for 400 million people. So what happens is kind of like the old school board mentality. It's a screw up and move up situation. So we just take idiots and rotate them from hospital to hospital to hospital. And there's no new thought. There's no new practice. And it's a very defensive model where it's all about protecting the health system, protecting the hospital. And we do that at the cost of the physician and the patient. Um, so whenever I was working for technology or whatever, when I was working for large corporations, they understood what they were trying to get to was the widget. But to do that, you had to enhance the physician and the consumer relationship. And that's what some of the things that have been built out by technology that's now going to be a risk, but they were much better at doing that.
So it reminds me of I don't know if there's a book by Brian Alexander called The Hospital. I don't know if you've ever heard of or read that book.
I've heard of it. I've not read it.
He's an investigative reporter, and he spent like 3 or 4 years at a small hospital. I think it was in Ohio. And the whole basis of the book basically could be summed up. It said that doctors and nurses, basically all the staff, are just pawns that are being moved around on a board, basically. This is the whole gist. And I was like, man, this is crazy. That it's crazy that the executives, CEOs, the bigwigs of the hospital don't come out and say that or admit that, or they kind of hide it, like you say, they guard it, and that physicians don't recognize it, and staff, nurses, they don't recognize, hey, we're just pawns here. It's just interesting.
Well, just think about it from like a monetary perspective. Someone, let's say, now I have a lot of education, unfortunately, and paid a very high price for it. But the average hospital CEO, has a 4-year degree, and most now have a master's. But that master's is usually somewhere around 24 hours, some less than 24 hours, graduate. And it's, it's the same people that they have MBAs. Most of these are now, masters in healthcare administration. There's no reason to disparage that, but just compare that to a physician who has spent all of their time, 12 years secondary education, then you've got 4 years of undergrad, then you got 4 years of medical school, then you got 2 to 6 years of residency and fellowship. Just depends on the physician. All of that time, and you've got somebody in a C-suite telling you when you can draw a CBC. No, I need them another night. That's insane. That's insane on its face that we have people talking about that. Or we're going to open a clinic in this location, and it's going to be this type of clinic, and I want you to drive from here to here, and I want you to do these procedures in this clinic. It's just insane on its face. And yet we allow it to continue kind of gleefully. I do think that physicians are starting to kind of get a picture and dial out that, number one, this isn't the Mensa society that's running these hospitals. That physicians, if we just took median income, median salaries, they're making around $325,000 a year in the United States. That's median for salary physicians. Meanwhile, the CEO that's employing them, the median is $1.2 million. And so there's this great disconnect that I think people are starting to see. And, there's a little bit of a pushback that's happening. It's good to see.
Yeah. Yeah. So in our state, South Carolina, where I'm at, 83% of physicians are employed. And so hopefully we're going to see a swing back in the other direction, more independence. But from a hospital executive standpoint, explain to people why hospitals want to own physicians. I mean, I'm assuming they want more cogs in the wheel, right?
You want more cogs in the wheel because a hospital doesn't really work on fee for service. Most people don't understand that. So if I'm a hospital CEO and I'm running a system, I am looking at, number one, arbitrage. I'm making a little bit of money on a transaction. So I need more transactions to have more arbitrage for that margin to work. And then the other main line of revenue is subsidy from the government, state governments, local governments like millages, and of course the federal government. And so I don't make money on fee for service. I need physicians who have prescription pads who are writing prescriptions in my 340B provider-based clinics. So I make an arbitrage on the drug. That program was designed to reduce drug costs for consumers, but what ended up happening was it became a bottom line buffer for hospitals. And no one got lower cost drugs. In fact, drugs went up because of that. But I need your prescription pad to do that. I need physicians in my provider-based clinics to generate something called a technical component. So I need to harvest your productivity. Every CPT code you perform, I need to make a little bit of arbitrage on that, a technical component that drives to my bottom line. And then, of course, I need more physicians to inflate my costs artificially to put on my cost report to send that to Medicare and Medicaid, so I get other kinds of disproportionate share payments and different subsidies and grants and subprime loans from USDA, HUD, SBA, HRSA, all these agencies. So I have to have physicians to do that. And then I would think the third part, which hospitals and health systems really aren't great about, but they should be, is capturing the market. They do that by kind of regulatory capture, but that would be the third and final. So it's really arbitrage, subsidy, and artificial market capture.
Yeah. That's a lot. That's a lot of wrap your brain around right there. That's
Yes.
a whole hour long lecture probably just in
That's
that
exactly
alone.
right. And if physicians would leave that really matrix, not to mock that, but if physicians would leave that system, our costs would decrease. It is cheaper for me to see direct primary care than it is for me to go to a health system owned physician. And it's not cheaper by 10%. It could be 100% cheaper than going to a hospital-based physician. It is it's crazy the amount of money that I spend on direct primary care versus what it would cost if I was to go to a hospital-based physician.
You got a direct primary care doc near you?
I do. I use an MDVIP. There's two MDVIP physicians here in New Orleans. Right. I'm not shilling for MDVIP. I had no connection, but it was a doctor that physicians went to, and he got tired of working in a particular health system. We only have two here in New Orleans, and he wanted to do his own thing. And this company had a framework for him to do it. And he sees 800 people. That's his panel, and you get his cell phone number and a free yearly exam with lab work and all of these, things. And it's a very different model. He calls to see, or he'll have his nurse call to see, how am I doing once a month? What is my diet like? Am I going to the gym? Or can run by and check this lab once a quarter for, whatever. And it's totally different. It's a very different alignment for me. And I've been using them for 12 years. And I love it. I would not do anything different.
That's good. Along those lines of hospitals owning and physicians trying to get out, do their own thing. I think I could be making this up, but I swear I heard you say on a podcast somewhere, maybe on the Doctor's Lounge or somewhere, that 93% of patients follow their physicians when they leave within 180 days, something like that.
That's exactly right.
Is that you've seen that data before? You've captured that somewhere?
Yeah, I mean, I've done it. That's from our own data. One of the big things that we did from really 2012 to 2015 was provider-based clinics. And I'd roll out 100 at a particular hospital, 70 at another hospital, 40. I mean, just tons of these. And what we found was that patients were physician loyal. They're not system loyal. So if I want to steal a physician to capture a market, I knew that I was capturing the patient base. So if I'm a tertiary care hospital and I want to start a stroke program, I find the physician with the most patients in the market, the most name recognition in the market. I'll go steal that patient. I'll go steal that physician or hire them away, and I'm bringing that patient migration with me. They do not stay at the system; they follow the patient. They follow the physician every single time. And if a physician goes direct or goes primary or goes concierge, whatever that's, different people
Mm-hmm.
call it different things, but the patient will follow the physician. Almost 100% of the time.
So what does that say about non-compete uh, for hospital systems? It's almost a losing battle for them.
It absolutely is. The problem is that people don't want to test non-competes. And I will just tell you,
Mm-hmm.
being on the other side of the non-compete, what lawyers would tell me. Lawyers would tell me that a non-compete is not worth the paper it's written on, but we do that to bully and fearmonger the person signing it. We want
Mm-hmm.
you to think that this is hard and fast. It is not. The difference between you and the hospital is the hospital has much more money to spend on legal than you do, and fighting a non-compete all day long can be $250,000. And so, but would you win? Chances are yes. You would definitely win where it's most important, which is in the public sphere, and that's what hospitals are very afraid of now. They're
Mm-hmm.
they're very, very afraid of being dragged through the mud in a local community. And if I ever want to strong arm a health system, I'm not really worried about doing it in a court. I do it in the community, and I'm going to go right at them in a very public way and shame them into compliance. But a
Mm-hmm.
lot, I do that for a living. But that's a major uphill battle for physicians, and that's not what they do, and it's not how they
Mm-hmm.
work, and it does not feel very natural. Uh, so unfortunately, non-competes are part of that regulatory capture that bully physicians into submission.
Yeah, we're trying to pass a law here in South Carolina to get rid of them. And boy, springing out the big hospital executives, man.
That's exactly right. We've tried that in Louisiana. It doesn't work. We tried it year after year after year. The group that always comes against is the Hospital Association. You're going to see that over and over and over again. Trump
Mm,
tried to do it right in the first year with the FTC. When was that? Right at the beginning of 2025 or the end, maybe? Yeah, beginning of 2025. And then what happened? Magically, that goes away. Why? The American Hospital Association. And
mm,
um, it will come back up. And the more physicians who test that, and I think what you're going to see probably is private equity, who now owns somewhere around 6% of physicians. As private equity buys these things up, private equity is tired of paying hospitals the buyout on these contracts. So I think you're probably going to see more of this tested from aggressive independent physicians and probably from private equity as well.
yeah, it's crazy. We had one. I know one direct care, a DPC doc down in South Georgia that a small, fairly small hospital system, and they were basically dying on that hill. They would not let this person. I mean, it was like a massive, like a 75-mile radius. It was ridiculous,
Yeah,
and they
I,
would.
I can't tell you the name of the hospital, but I just opened a new physician-owned hospital, and they had a very particular subspecialist, and it was extraordinarily acrimonious to get her freed from that hospital. And at doing it, I felt like the dang Harriet Tubman of physicians trying to get this lady out. It was
Mm,
crazy. And we probably spent somewhere in the neighborhood of $65,000 on legal fees, just writing letters back and forth. And the only way to do it was to really shame this hospital in the public sphere. Um, and even doing that, they made it very difficult for patients to find her. They would not tell patients over the phone where she was at. They wouldn't give her phone numbers. They made it incredibly. I remember one of the last legal issues we had was getting medical records, which is a violation of the conditions of participation for Medicare, Medicaid. To withhold that, that's a patient right. And so, but it was extraordinarily difficult to get her out. And that was just, what, 2 years ago. So I know it all too well. And these are people that I know and like who run this hospital. It was,
Mm.
it's going to create a major, because she was a particular specialty. It was going to create a major hole for them in their bottom line related to 340B and provider based reimbursement.
Yeah. So what happens? This is an off the wall question. You've mentioned 340B a couple of times. What happens if a lot of people want to get rid of that? They think it's
Yes,
not
you should.
helpful and we should get rid of that just because it makes the cost of everything. What happens? Does the hospitals, they lose big if that goes away?
They lose huge. Yeah, it would be big. It would be big, and I mean, I think it could be so big to where maybe a third of hospitals close.
Mm.
Um, and hospitals really won't close. Well, it would be a great opportunity for physicians, particularly in rural areas, to go acquire those hospitals for debt, where there's no cash exchange, and you just pick up the hospital debt and move down the road. Um, it's sadly probably going to be a lot of private equity and a lot of these tech companies who are going to go after some of these hospitals. But if 340B were to go away tomorrow, all day long, 30% of hospitals would probably close. I mean, it is a big number. The other
Mm.
thing they would have to do is radically offload their clinics. And that would be really a cost benefit, because some of these clinics get large provider based revenue. So then they have to decide, am I going to offload these? Do I let the physicians buy them back? Do I sell it to private equity? How do I get rid of these? So it,
Mm.
I think we need to get it. I think we need it to go away. I think HHS knows it has to go away. The math is no longer sustainable here in the U.S. I mean, we spent $5.6 trillion in 2025 on healthcare in the U.S. Whenever you account for indirect spending, it is absolutely at 20%. It's not just 18% of GDP; it's 20% of GDP. Whenever you account for indirect spending, not just NHE, national health expenditure, that number is not sustainable.
Mm.
20% of our GDP cannot be spent on healthcare. Oh, I think it's over half of federal dollars now are spent on healthcare, more than military and Social Security combined. That's not sustainable. And just because we want to have nice art in a $4 billion ambulatory care center, I mean, you saw what happened at the University of Miami in Florida.
Mm.
That's obscene. That I
Mm.
cannot believe we're doing that. And the numbers just don't work anymore. So something has to happen, and it has to happen quickly within the next 18 months.
Yeah. So we hear about the 340B programs. We hear about obviously the repeal the physician ban on hospital owning hospitals and site neutral payments. We hear about,
Yep.
um, and then I guess the site neutral payments, does that include like the hospitals get the extra fee? Is that all in that site neutral payment stuff?
That's that technical component, that provider based thing that you hear a lot, provider based, or the technical component of thing. That's where you go to a direct primary care and pay $35 for an EKG. If I go to the hospital, I'll pay $350 for an EKG.
Yeah,
So
yeah.
that's that component. And then the other one I would add to that is probably provider taxes, which
Mm.
HHS is underway right now. But that's just a way to game Medicaid, and it's a way for states and local governments to do that, and it go back to hospitals. Note: physicians cannot participate in 340B, provider taxes, provider-based clinics. They can't participate in any of that,
Hmm.
and so it's only geared towards hospitals and health systems.
Yeah. So the physicians are getting railroaded. We've done a very poor job. I've heard many people say this, like Mark Cuban. I spoke with him recently, and he basically said to my face as a physician, "You guys suck as physicians with your raising money and your lobbying and your legal aspect. You guys are terrible at that. So you have no voice."
You have no voice, and just basic. I will have to tell you, since 2020, it's been maddening trying to help physicians. I've never met a group of professionals who get mad at each other and work in such a very defensive way. And that has to be from training. I still have not sat with that long enough, but I think it's from residency. But, HVAC doesn't work that way. I don't work that way as a consultant. I want people who represent physicians to do well. I want, I want you as a physician to do well. And you don't have to pay me for me to say that. I'm not worried about the market. And I think that's kind of, physicians have been beat over the head with that for so long and been made to fit in this very rigid system, and are trained to be risk averse. That is the very nature of a physician, that it's working against them. And so whenever you ask a consumer who is driving the cost of care in this country, they don't know anything about hospitals and health systems. Who do they blame? They blame the person they see the most. They blame a physician. Why do you think so many people are up in arms about drug cost? And drug cost is 8% of NHE, national healthcare expenditure. We could eliminate all drug costs today. It means nothing, but it gets a lot of attention. It's because that's who people see so much. They go to a pharmacy, they see a pharmacist. They're dealing with that in volume, but it doesn't translate to expense. 49% of our national healthcare expenditure, almost $3 trillion, is controlled by 6,093 people. That's how much went to hospitals and health systems, not physician-owned hospitals, governmentals, rurals, critical access hospitals, large health systems. Physicians have got to find a way to take their voice back and to tell consumers we're not the problem. But physicians wanting to speak up, to say, it's some slappy down the road at Congaloo Baptist Hospital. It's not us creating this. So I do think physicians are starting to find their voice and get a little courage. I'll just keep telling them, if you'll stop focusing on each other and be helpful to each other, you have an unlimited market. There's only 1.1 million physicians left in this country. 35% of them will be retiring in the next now 48 to 54 somewhere months, less than 5 years. That's by their own admission. Out of that 1.1 million, 69% are owned by health systems alone. Another 11% are owned by Optum, 6% are owned by private equity. There are only 208,000 independent physicians left in America for 400 million people. Of that 208,000, 53% of those are primary care. The market is as infinite as you couldn't ask for a better market. So there, if you left today as a physician and wanted to open your own thing, you would be saturated with business because there's no one doing it. You have no competition. But there's this thought that there's all of this competition that exists, and it makes physicians very defensive. But if you all would work together and have one common voice, you could make a lot of changes.
Yeah, definitely. We need a common voice. People talk about the AMA, which has never been a real good voice for physicians. Maybe in the 60s, in the 1960s, maybe, but they're not a voice. So there's really no voice out there. I think there's some groups that are trying to do more and more, but.
Well, and remember this, I've got friends that work at the AMA. I've got friends that work at the American Hospital Association. Just think about it and don't make a value judgment about it. Just look at the pure mechanics. So who does the AMA represent? Physicians. Who owns the most physicians? Hospitals and health systems, 69%. So if I'm the AMA, who do I hew to? A physician or the people who own the physicians? I'm going to do everything in my power to work with the group that owns the physicians, thinking I'm helping the physicians. That is the thought process of the AMA, along with the fact that they really make all their money from coding, CPT codes, HCPCS codes. They control that. So that's where they, physicians to them, unfortunately, is a widget. And then medical societies have become this weird again, artificial competitive thing that tries to box certain physicians out and doesn't really work to represent physicians.
Mm-hmm.
And medical societies have gone just by the wayside as well. So um, physicians have got to find a new way to unify, come
Yeah.
together, and learn that, yes, unfortunately, I wish I could say something different, but state politics, federal politics, it's all run by money.
Yeah.
You got to have some money. You got to have some organization.
Yeah, we could. We have a lot more power. Physicians have a lot more power than they realize. They definitely got to
Yes,
stop stabbing each other in the back
that's
and,
right.
doing stupid things. But, it wouldn't take, if you could get half of us, if you get a 500,000 of us to actually hold hands and do something, and each, if 500,000 gave $5,000, you'd have a bunch of money to lobby,
You'd have a bunch of
ton of
money.
money.
And that's what a lot of people don't. When we look at money in politics in aggregate, but um, I know I'm friends with someone who's, not to identify him, I don't want him to be associated with me, but he's, let's just say he's in the top 10 of people in government. And but I have to pay a max campaign donation to that guy to get a meeting with him. And I've known him forever, and would spend way before he was in politics, would spend an hour with him a day on the phone. um, and it's just the way it works. And so, but 2,500, $5,000, $10,000 can get you far. It doesn't have to be $1 million check. These are parasites. So and you got to treat them that way. It's just a little bit of money goes a long way in that world.
Mm, it's crazy.
Nuts.
So back to the hospital and physician, specifically primary care. The one of the craziest questions or things that I think about a lot is how do hospital CEOs, executives, people sitting in the C suites, how do you square up the problem of primary care, what we do, and specifically in direct primary care, where our focus is the patient. How
Yeah.
do we keep the patient out of the hospital? How do we keep them from going for testing specialists? We don't want to refer people.
Right.
How does a hospital CEO square that up with primary care? Obviously, they're just using them as widgets, but we, as direct primary care, on the outside, we're trying to do everything we can not to send people to the hospital.
Right.
So, in my brain, I'm trying to square up. How does a hospital CEO square up what our mission in primary care is to prevent illness, prevent these referrals, all this preventive stuff, but the hospital CEO is like, no, keep sending people to us. How do you square that up?
Yeah. Well, what I would want as a hospital CEO, as a health system CEO, I look at primary care as a gatekeeper. So I need, that is my baseline referral source. And I really don't want a physician to manage those patients. I want a nurse practitioner to manage those patients. And I want to drag my physician into more hospital-based care. And we sell that to you as we want you managing complicated patients. But really what I want is a nurse practitioner who I can really keep my thumb on to keep them in what we call, and I've got a slide on this, but what I call a referral loop. So I need them to go from encounter to imaging or to diagnostics in a loop to a specialty back to primary care. And I need this loop to continue. And that professional loop and diagnostic loop feeds my other modality loops: home health, hospice, inpatient, LTAC. So that loop continues and it shoots out these other verticals. So I look at primary care. Most hospitals and health systems, we look at it as you're a control source. So you're the baseline of referrals. So we need you to make sure oncology functions. We need you to make sure our cardiology service lines function, and you feed that. So it's a gatekeeper look, and that's exactly how payers 20 years ago looked at primary care. And which is why payers wanted to become a payer provider, which is why Optum owns 10% of physicians. If I can own the gatekeeper, I can manage the rest of that care.
Yeah. And that's pretty much in direct opposition to what direct primary care is all about,
Right.
unfortunately. So there's a lot of animosity between what we do in the local hospital system because we're not feeding the system at all,
Right.
which is interesting.
Well, and remember, let's just say, let's just take a round number. Let's say $1 million. If I have $1 million health spend, and this is what I do, go into corporations, because direct primary care works so well with large corporations
Mm.
who have a large health spend. If I want to drive my health spend down at I won't tell you the name of the corporation, but let's just say one of the largest animal protein producers in the world, and they were having a lot of ER utilization. Well, all I need to do is hook them up with direct primary care. And if their spend was $1 million, direct primary care drives their spend down to $250,000. Then I can share a savings with direct primary care. I can either do that on a capitated basis. I can do that yearly with a shared savings, quote unquote, shared savings program. But I've driven my costs down by, $750,000. Let's say I'm just saving 500 grand. I redistribute another 250 grand to my direct primary care. I'm still saving $500,000. That's what I'm trying to sell on a macro scale.
Mm.
If we can, doctors can make more money by saving the system money. It's crazy. It's
Yeah,
crazy.
yeah.
But if I can drag patients out of the hospital cycle, the referral loop, and place them with competent physicians who are incented differently, I can use existing dollars. We don't have to have any new dollars to pay physicians more and save consumers money. It's crazy, but it's true.
Yeah. And I think you're starting to see more and more employers want that.
Yes.
They want direct primary care. Like you got Mark Cuban speaking about it every day, wanting direct primary care, encouraging other employers. You got to get direct care. You got to keep people from going to the hospital. You got to prevent.
Employers don't know about it. They don't know about it.
Yeah, I
And
know.
and if and remember, I can't remember what politician said it, all politics is local. It's the same thing for economics. If you've got the top 5 self-insured businesses in your area and you've not talked to them, that should be on your priority list. Go and meet these CEOs. Healthcare is controlled by an HR person in a little cube that no one in the corporation even really knows exists. But that's who really shops these policies and these third-party administrators. But anybody who has about 300 employees or more, that's sheriff's departments and county commissioners and school boards. And, you don't have to go after Walmart, which is typically the largest employer in areas.
Mhm.
Go after people who are self-insured. You can save them without even looking at one document. I can tell you for a fact, you can save them a TPA fee of 10% off the top. And that is the next big boom. Mark is exactly right about that. Business and industry contribute the most amount of money to the insurance program that we have in the United States. And the driver of cost is not insurance companies. The driver of cost is that 49% we talked about of NHE. It's hospitals and health systems that are driving that cost. So if I can get them out, we can reduce their cost.
Can along those same lines, I guess you got big hospital systems, you got smaller rural hospital systems. Can employ more and more employers are looking to do the direct contracting. Can hospitals can they make it with direct contracts with even like a small employer 300, but maybe even a 1,000 member? Can they do direct contracts and make it for like CTs, MRIs, procedures? Can they manage it and do well as a hospital system with direct contracts?
They can, but that is not their current business model. The current business model for a rural hospital in the United States is incentivized dysfunction, and the government created that. So the more my care costs, the more reimbursement I get, and I get that through arbitrage and subsidy. if I was to take Medicare and Medicaid away from rural hospitals in the United States, from any hospital system, they could not survive. You know, you hear all these hospitals talk about physicians are cherry picking and blah, blah, blah. If I went to a health system and said you could have 100% Blue Cross Blue Shield, do you think they would take it? The answer is no. They couldn't survive on it. They only survive on arbitrage and subsidy. And most people don't understand that. So what you're talking about is a very cogent, common sense business model that is absolutely foreign to hospitals and health systems. They wouldn't even know how to set it up. You know, they're so busy talking about DRGs and provider-based technical component and you know, this 340B arbitrage and getting uncompensated care dollars. They would not know how to survive on that. That's why I've been pushing physician-owned hospitals. Physician-owned hospitals are lean. They're cheap to build. They are typically focused on specialties. You know, and that's what the consumer wants. If I have a spine problem, I want to go to a spine hospital. If I have a women's health problem, I want to go to a women's health hospital. I want to see those experts. And then you find people like yourself, direct primary care, who understand the model and who just sometimes need that framework to treat patients, and you plug and play, make it modular. That's been my big selling point, because the system cannot continue this way. And as we move more towards aligning with business and industry, it's going to catch hospitals and health systems, particularly rural hospitals. And we have almost 2,000 in the country, 1,960 some odd rural hospitals. It's going to catch them right on the chin.
Yeah, you would think that there would be some. I mean, you said yourself that hospital CEOs are not very smart people, but you would think there'd be somebody out there thinking, man, we've got all these employers in our area. Let's do direct contracting. Let's get away from this other stuff and let's get cash. Let's get paid cash for some of these things. And like, you basically collecting like, hey, we know for these 10 companies, we're going to get every gallbladder surgery and we're going to get every knee surgery because it's a cash deal. You'd think there'd be some people thinking ahead to think about that.
You know, one of the best hospitals, and they're here in Louisiana, one of the best hospitals that does that is Baton Rouge General. They have a small health system, but that is their bread and butter. That's what they do. They are extremely good. Edgardo Tenerio, Kendall Johnson's the CFO. I wish hospitals and health systems would go to Baton Rouge and see how they do it. I mean, they make it work. They work with a very large medical group, and sometimes they have an adverse relationship, but it is, you know, you need that for that to work. And so it is a great model. I do not know why. Well, the reason they don't do it is because other hospitals are incentivized to keep this charade up. But what I keep saying is that it's eventually going to come to a place, just number-wise, where the math doesn't work. And I think we're there. I mean, we've been talking about this for 20 years, but now our national debt is not serviceable. It's $38 trillion. And, you know, we're adding somewhere in the neighborhood of $650 billion a year debt-wise just on healthcare. It's not sustainable. It will implode.
Yeah. Along those same lines, what works and what doesn't work in hospitals, we've seen a few hospital systems try to do direct primary care. They call it that.
Right.
Not usually never works out because they don't really know what they're doing. They don't run the system the same. I mean, direct primary care typically is a low overhead. There's no meat on the bone. Like after I pay all my staff and, you know, everything, there's not a lot of meat on the bone left. So you're not making a ton of money doing that.
I've done a lot of work with private equity. Private equity is they get their teeth kicked in every time they get in healthcare, and they have to get in healthcare because it is 20% of GDP. So I mean, that's $6 trillion that they're missing out on if they're not involved in it. And I think they do some things really well. I think they do commercial real estate really, really well in the healthcare space, if they will stay on that. But the moment they try to get in delivering the care, they get their teeth kicked in. They don't understand it at all. And it's not something a 25-year-old on Adderall sitting in Miami or Austin or New York can do. and it doesn't really work with the physicians and their team, and it's because of how lean you all work, and that's what and that's the magic of it,
Hmm.
what I think is happening is we're kind of coming full circle, and we're going back to this idea of small community physicians, and even in urban areas, I mean, small community physicians that represent 800 to 1,500 patients on a panel, that the patient pays in cash and has services in cash, or that their employer direct contracts with, and their patient has some kind of copay for utilization or something like that. But we've got too many hands in the pie right now that are making it artificially high, that are unnecessary costs.
Hmm.
And to get the cost down, we've got to get those intermediaries out, which is
Yeah.
great news for physicians and consumers.
Yeah. It seems like people want to talk about prices all the time, hospital prices, cost. There's all these words they throw around about everything costs so much, and it seems like to me that buka the bukas out there and hospitals are kind of in cahoots, and
Yes.
so that nobody cares whether the prices are going up. I don't know if there is an answer, but everybody wants to know why does everything keep going up every year? It gets more and more and more expensive. I say it's because the insurance plans and hospitals are in cahoots together. To be honest, and they they want the prices to go up. Insurance doesn't care because of the MLR. They don't care whether the prices go up or not. Hospitals just want to keep jacking the prices up. So it's crazy how prices just seem to keep getting out of control.
Yes, that's exactly right. So hospitals and health systems work with a baseline of my base costs are going to increase 7% a year. That is a baseline expectation. So they don't even work to reduce costs. They just want to keep it at 7%. If and again, we're talking about a very simple concept: dislocation of capital. If I was to go sit in front of a healthcare CEO today, some hospital executive, and I said, tell me, what is your CT manufacturer? Who manufactures your CTs? They couldn't tell me.
Mm,
They couldn't tell me how much it cost to. They would look at their cost report, which is completely artificial. It's completely made up numbers. It's made up to game the system. But if I went to a physician-owned hospital today and I said, "Hey, where are you buying your 4x4s from?" They would tell me exactly the manufacturer they're buying the 4x4s from and how much they cost, not per pack, not per case, per 4x4, because it's coming out of their pocket. So when the capital's dislocated, I have no incentive to control cost. And when the market is such that you've got 6,000 hospitals and 400 million people, I know that I have a captured market. It is completely captive to me. I have no incentive to reduce costs. And then my productivity is based in physicians, and I've got you trapped in non-competes and contracts, and you're not leaving this area. And physicians want something that's very simple. They want a 3-bedroom, 2-bath house. They want 2.5 kids. They want a dog and a half and a white picket fence, a Yukon, maybe a Mercedes. Maybe that's a little
mm,
much today. Physicians are very simple, and if I can get physicians to have that, then I can keep them trapped in my system forever. I can keep them
mm.
employed and keep them trapped. So it's real simple from the hospital side to keep taking prices up somewhere between 7% and 20% a year, because capital is so dislocated.
So I envisioned in my head that the hospital has a master fee schedule. What they have, their master, and it's the beginning of the year, and the CEO slaps the IT guy on the back and says, "Okay, make those changes, Billy." And Billy goes to the computer and changes all those fees. Change every fee up 7% for us, and
No,
bam.
that's exactly what they do. But it's worse than that. They pay a consultant to do that. There are charge master consultants.
Mm,
What they do is come in, they take an Excel file, and they literally change the fee up 7%. And then you pay them, $150,000, and they give you a nice little shiny 3-page thing, and that's it. That is actually how it works. It is not.
Mm.
It is not at all by CPT code, or occasionally you're going to have to negotiate a certain service array with insurance
Mm-hmm.
companies, but it's more asinine than people think. I mean, it's kind of insane how we do this.
Yeah, that's crazy. Coming up on the top of the hour, so I want to respect your time. I want to give you one last chance to hopefully to share this video with hundreds and hundreds of direct primary care physicians, primary care docs, people thinking about getting out of the system and doing primary care. So I wanted to try to give you from the other side, from the administrative side, give them some hope, share with them where you think things are going. You've kind of hit on a little bit that you feel like this is a great time. Employers are really looking. There's the need is out there. So share a little bit with some hope for DPC docs and give them some encouragement. Hey, you can do this, and there's going to be a lot of patients for you.
Well, that's that. The math is simple. I wish I could make a really good sales pitch. I'm not very good at it, but just let the math be on your side. There are so few physicians for 400 million Americans. And what is the top um, item on their mind? All surveys, all polls say the same thing. It's healthcare. And what we're seeing right now is a major change in healthcare, that people are starting to be consumed with their wellness and their longevity and their productivity. And they don't get that at hospital-based clinics. And physicians, also Americans are starting to think very local. We don't just see that in healthcare; we see that in other sectors as well. And so, if you are a physician today, just look at the math. The math is on your side, and you offer something extraordinary to business and industry, real cost savings, tangible. You make money by saving other people money. I mean, that's a that's an amazing place to be in. It's the sales. Your sales pitch is math, and we're all going to be more healthy, more happy, more wealthy as you all take this initiative and assert yourself in the health system. And so if I can encourage physicians, is to really take a hard look at DPC. The numbers are on your side. It is it feels like a risk, but it's really not. It's easy. You're going to have a little 90 to 180-day tension, and then everything sells. It goes real smooth after that. And it's not a hard business to run. I think everybody should be looking at it. This is where you should go. This is the future.
Mm. The only people that are going to be unhappy are the hospital CEOs.
That's exactly right. The hospital CEOs, and whenever you start, just be aware. Whenever you start aligning with business and industry, insurance companies, because remember,
Mm.
they make arbitrage on healthcare being expensive, so they don't want you to come in and reduce a company's healthcare costs. They don't want you to
Yeah.
reduce that spend. So know that tension exists too. But yeah, hospitals and health systems and payers don't want you going independent. Don't want you going cash based. They don't want you aligning with business and industry. Um,
Mm-hmm.
but everybody else does. And it
Yep.
works 100%. The data is so clear on this.
Sweet. Awesome. Thank you for your time today. And hopefully we
Absolutely.
can continue to share with each other and learn. That's what we need to do.
That's it. That's it. Y'all got it.
Thank you.